Hi everyone, welcome back to my YouTube channel and today we are going to talk about Pemphigus vulgaris. So let's start our topic with introduction. Pemphigus vulgaris is a chronic, life-threatening autoimmune vesiculobullous disease that is characterized by intraepithelial blister formation in the skin and mucous membranes. The oral mucosa is often the first site of involvement and lesion may precede skin manifestation by months. Without treatment, the disease can be fatal due to fluid loss, infection, and electrolyte imbalance. Early diagnosis and management are therefore critical. Epidemiology of Pemphigus vulgaris. It occurs mainly in middle-aged adults like 40 to 60 years of age. It has slight female predominance. It is more common in people of Mediterranean, Jewish, and South Asian descent. Its incidence is 0.1 to 3.2 cases per million annually. Etiology and pathogenesis of Pemphigus vulgaris. First, it has autoimmune mechanism, as Pemphigus vulgaris is carried by autoantibodies that directed against desmoglein 3 that is found in mucosal epithelium, desmoglein 1 that is found in skin epithelium. These desmogleins are components of desmosome that are the structure responsible for cell-to-cell adhesion. Autoantibody binding causes loss of cell adhesion that is called acantholysis, formation of intraepithelial blister, and the fragile villi that rupture easily. Then there are genetic factors that increase the uh, pathogenesis of the Pemphigus vulgaris, HLA-DR4 and HLA-DR14 association, and it also shows strong familial pattern in some cases. Then there are triggering factors for Pemphigus vulgaris that include physical trauma, drugs, for example penicillamine, percaptopil, rifampicin, and NSAID, stress, and viral infection that can contribute to Pemphigus vulgaris. Clinical features of Pemphigus vulgaris. First is oral lesion. They are the earliest and most persistent manifestation of Pemphigus vulgaris. There are painful blisters that rapidly rupture. There are irregular erosion on buccal mucosa, lips, and soft palate. There is difficulty eating, drinking, and swallowing. There is also desquamative gingivitis associated with Pemphigus vulgaris, and lesions heal slowly without scarring. Then there are skin lesions in Pemphigus vulgaris that are flaccid bullae on the trunk, scalp, face, or extremities. Their blisters rupture easily and form superficial erosion. These erosions are oozing, crusting, and there is risk of secondary infections. Then there is Nikolsky signs, that is, when gentle pressure is applied on skin or mucosa that causes epithelial peeling. It is highly suggestive of pemphigus. Then there are systemic factors symptoms associated with pemphigus vulgaris that include malaise, weakness, and dehydration that is caused by electrolyte imbalance in severe cases. Histopathology of Pemphigus vulgaris. Biopsy is essential for diagnosis, and microscopic features show suprabasal clifting that is split from just above the basal layer. Acantholysis, that is suppression of epithelial cells, and T-zinc cell can also be seen that are rounded detached epithelial cells. We can also do direct immunofluorescence for diagnosis that show fishnet or honeycomb pattern of immunoglobulin G and C3 between epithelial cells. We can also do indirect immunofluorescence that shows circulating anti-desmoglein antibodies in the blood. Diagnosis of Pemphigus vulgaris. First, we do essential methods that include clinical examination, biopsy and histopathology, direct immunofluorescence, serum antibody titers. And we can also do additional tests that include complete blood count, liver and kidney function tests before systemic therapy is done, and also nutritional assessment. Differential diagnosis of Pemphigus vulgaris. Pemphigus vulgaris must be differentiated from the mucous membrane pemphigoid, that is subepithelial blister. It should be distinguished from bullous pemphigoid, erosive lichen planus, Stevenson-Johnson syndrome, erythema multiforme, linear immunoglobulin A disease. Management of Pemphigus vulgaris. First are the general principles of management that include early aggressive treatment that prevents mortality. Multidisciplinary care should be given, like dermatologist, oral medicine specialist. It is important to maintain oral hygiene and manage pain in general and early stages. Then management involves pharmacological treatment in which we can give systemic corticosteroid that are mainstay of treatment that may include prednisolone 1 to 2 mg per kg per day. It causes rapid relief of lesions and there's gradual tapering of dose once the disease is controlled is done. We can also give immunosuppressive agents that are used as steroid sparing agents. For example, azathioprine, mycophenolate mofetil, cyclophosphamide, methotrexate. We can also give biological therapy that include rituximab, that is anti-CD20 monoclonal antibody, and it is now considered first-line therapy in many guidelines. There is dramatic reduction in disease activity with this biological therapy. We can also give adjunctive therapies that include intravenous immunoglobulin and plasmapheresis, that is for severe refractory cases. For management, we also give supportive treatment that includes topical corticosteroid for localization, antiseptic mouthwash like chlorhexidine, analgesics, nutrition supports, for example, soft diet is given, and dehydration is managed using ORS or different things. And secondary infection is treated by antibiotics if needed. Complications of Pemphigus vulgaris. A Pemphigus vulgaris can cause secondary bacterial infection, dehydration and electrolyte imbalances, corticosteroid side effects like diabetes, hypertension, and osteoporosis. It can cause opportunistic infection from immunosuppressants and it can rarely cause sepsis. Prognosis of Pemphigus vulgaris. With modern therapy, mortality reduced from 90% to 10%. In chronic disease with periods of remission and flare-ups may happen, and early detection improves long-term outcomes. Conclusion of this lecture video. Pemphigus vulgaris is a serious autoimmune blistering disorder that primarily affects the oral mucosa and skin. It results from autoantibody mediated destruction of desmosomes that lead to fragile blisters and erosions. Timely diagnosis using biopsy and immunofluorescence along with prompt systemic therapy, especially corticosteroids and biologics, dramatically improves prognosis. And long-term follow-up and supportive care are essential to prevent complications and maintain quality of life. And this was all about Pemphigus vulgaris. Hopefully you liked the video. If you do, don't forget to like, share, subscribe and comment. Thank you for watching.